down share right now. Well, as we're complex tachycardias and then complete heart blocks, which would be probably next week or the week after. I'll send you out a notice about that. Last week we covered neurocomplex tachycardias. Neurocomplex meaning the QRS is less than 0.20 without any funny notches in it or anything that makes it wide. And the supraventricular tachycardias were all atrial fibrillation with uncontrolled response all the way through the sinus tachycardia, just as the nodal tachycardias and some of the other sinus tachycardias that you see depend on your determination whether or not they're narrow or wide. Once you go to narrow tachycardia, then you have to decide whether it's regular or irregular rhythm, and then you move from there. If it's irregular, chances are you're dealing with atrial fibrillation, which is the most common arrhythmia that's out there in the older populations. Most of it that is what you're going to be seeing in the field. All right, I think I got uploaded now to the screen. Can anybody see this screen? All right, very good. So as a review, the supraventricular tachycardias include atrial fibrillation, multi-atrial tachycardia, and just know that there's two types of MAT type of tach. First is going to be from digoxin toxicity. Digoxin poisons the AV node and slows it down so this cannot get through the AV node at one time. Physiology, once the impulse originates from the sinoatrial node, SA node, and goes to the AV node, there's about a 1/10 of a second delay before the next beat is allowed through. In atrial fibrillation rapid response, one of the older treatments for atrial fibrillation was to poison the AV node so it would have a 1-second delay. And as a result of that, even though the heart rate would be a little bit higher, the purpose of the digoxin was to poison it so that it would let through the 1 in 20 or 1 in 30. Atrial fibrillation, by definition, the atrial rate is between 300 and 400. It's just chaotic. And that's why clots form in there. It just fibrillates. It doesn't really beat, which could be dangerous for the patient. It's a main source of stroke. Many event the AV node then lets through a certain number of impulses. In a nice controlled patient, even though they've got atrial fibrillation, they can still have a rate between 60 and 100. But when the AV node is hyperactive, in other words, there's no medication controlling it, you can get into a tachycardia. Tachycardia is over 150. To further review, multifocal atrial tachycardia means about 2 or 3 focuses are firing, and they're getting through at an irregular intervals. And so, in addition to atrial fibrillation, which is irregularly regular, multifocal atrial tachycardia will be regular, and there's a very small distinction there, but it can go 2 to 3 beats, and then irregularity by 2 beats, 3 beats of regularity, and it interspaces regular with irregular. The 2 medications that cause that, you'll get this on the National Registry test, will be alpha toxicity and digoxin toxicity. Now, the rest of the ones, frequent EKG, and it doesn't really warrant much discussion here because it's not really on the test. Does anybody have any questions as a matter of review for the neurocomplex tachycardias that we covered last week? All right. Well, Matthew, glad you could join us. All right, what we're going to do is we're going to start covering wide complex tachycardia. Now, adjust your screen or do whatever you think you need to do to make this algorithm come into place as soon as I get done shaking it around. This thing's touchy. All right. If you've got the article obviously in front of you, go ahead and pull up that we had on narrow complex tachycardia. It asks you to make a decision between regular and irregular. In other words, if the rate is regular, it looks like a P wave is preceding each QRS and such, and it's marching out as a rhythm, even though it's a tachycardia, then you could use adenosine or a beta blocker or a calcium channel blocker to break it. Adenosine will probably terminate the sinus tachycardia. Just make sure that the sinus tachycardia be terminated. What I mean by that is this. If you give a resting heart rate right now of 80, you run a 100-yard dash and you come back to me at a heart rate of 130, I'm not going to give you adenosine to slow it down. It's your tachycardia. It's a physiological response. It's secondary to the primary problem, which is overexertion. Sometimes patients will come to you with hypovolemia, dehydration for whatever they're doing. And as a result of the dehydration, they could be tachycardic as well. It's one of the first responses to dehydration, or worse yet, loss of blood. Tachycardic as the first symptom of blood loss. Well, subsequently, sinus tachycardia in those situations, you don't want to really terminate because they're essentially physiological response and compensate for the underlying problem. So they're trying to compensate. Now, in this scenario, we're talking about a sinus tachycardia or worse yet, a supraventricular regular rhythm to it. In other words, they all march out fine. They all look like they're firing off at the regular. Boom, 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 boom. Nothing irregular like you see with atrial fibrillation, or it could be all over the place as far as 2-3 beats being close together, then a couple of beats being far apart, and they're variable in the rate, and it's just chaotic for atrial fibrillation. So regular or irregular, and then you take the algorithm there, and then you finally get to a treatment. Now, for the wide complex tachycardias, and here we go with the start of the lecture, wide complex tachycardias ask you to determine whether or not the patient has coronary artery disease. So when you get on scene and you find that the patient has a wide complex tachycardia, first thing, talk to them, make sure it's a stable or legal tachycardia, and then determine whether or not these patients have heart disease. So you'll be listening for and you'll be watching for, when you open up their blouse or their shirt, you'll be looking for that midline incision that determines that they've been heart surgery. But you have to ask them, what kind of surgery did you have? Some of them have open heart. And as a result of the open heart, have had a valve placement, not so much coronary artery disease. So you'll have to lead in with that question. You don't see any scars on the chest and such, and you're going to ask the patient, do you have a history of heart disease? Yes, my doctor told me I've had a heart attack. Okay. Did you have any stents placed? Did they have to do any procedures to open up the heart, called coronary angioplasty? And then you'll ask if there's stent placement. If that's the case, if they say yes, then you'll follow the algorithm down to yes. If they have a history of heart disease, and they've had, especially if they've had a previous MI, then the wide tachycardia that you happen to arrive on the scene for, more likely than not, and I'm going to say about 90% of the time, has been my experience, is going to be ventricular tachycardia. All right, so let's make sure that I've got everybody caught up here. Martin, Jamie, Jonathan, Matthew, George, and Grant, can you guys still let me know that you're hearing me? Just give me a Y or an N. All right, very good. All right, so that's the easiest part of the algorithm. Look, if the patient's had a previous history of heart disease, and you're going to get this on the National Registry. Last 3 tests that I've seen has had a question on this. Is going to be your patient is a 75-year-old male who has had shortness of breath, difficulty breathing, he's complaining of some chest pain, he's pale and diaphoretic. You notice that his blood pressure is 60 over 40 with a pulse rate of 1 tachycardia is on the follow strip. And they show you a strip just like the one that we're going to have here. As soon as it pulls up. Oh, maybe not. Yeah, where'd my wide complex cardio stuff go? All right, well, don't have it here. But you're going to have a wide complex tachycardia. It's going to look pretty regular. It's going to be very wide, and it's not going to give you any discernible P that you can remotely call QRS. With those vital signs, we have a choice. The choice is what? Can anybody tell me if a patient has a 60 over 40 blood pressure, 180 pulse rate, short and difficulty breathing, and altered mental status, what would be the next appropriate step? All right, good. Y'all give me a good answer. I throw a 12 lead on the guy and start setting up for a cardioversion. This patient he's got pulses, and that's the key here. He's got palpable pulses. He's got some altered mental status from the low blood pressure. It, by definition, is an unstable arrhythmia. And the thing that makes us unstable is going to be his alertness. The answer scenario on the National Registry, they're going to say if this patient is stable or unstable. And they're going to give you a list of vital signs and such. You're going to go to that part of the question where it describes their mental status. If the mental status is altered, you're going to go with your unstable algorithm. And there's just one box under unstable, and it says cardioversion. That's it. So your patient has underlying heart disease. You go to yes, go down to ventricular tachycardia because 95% of these are going to be VTAC. And then you're going to go right into cardioversion. Now, most, if not all, systems are still carrying amiodarone. And so after your cardioversion, you'll want to start the patient on an amiodarone drip. Amiodarone is going to be very safe here. Here's the caveat. We talked about this last week again. Adenosine in a narrow complex tachycardia situation, adenocard, 12 milligrams IV push, and even if they're narrow complex, if it terminates the arrhythmia and they go back to normal, it was probably a sinus tachycardia or AV nodal reentry or one of those other happy ones that give you a nice regular tachycardia. If it doesn't terminate it, but just slows it, probably dealing with an atrial fibrillation, atrial flutter, things like that. It's a great way to distinguish what kind of rhythm that you got. Adenocard is a good first-line choice for any narrow complex tachycardia. Now, if it's wide and you give adenocard, there's a good chance you're going to make this patient more unstable. If he's stable, you'll make him unstable. If he's unstable, you'll stabilize him by making him have zero vital signs. In other words, dead. Dead is stable. They're not going to change. Unfortunately, that's not going to lead to a successful. So back to wide complex tachycardias, we don't use adenocard. But you do have amiodarone. And you do have cardizem. But I would watch you use a cardizem. It seems to be the safe play, and we'll explain why. Let's go back to underlying heart disease. And yes, he does have unstable vital signs with underlying heart. You go right down to ventricular tachycardia will be your diagnosis. You're going to go cardioversion and then start amiodarone. If your system doesn't carry amiodarone and you're carrying procainamide, which is procaine, you can go ahead and start with whatever your protocols call for, but it should follow this clinical practice algorithm. Now, back up to the top. You've determined that the patient has wide complex tachycardia as you hit the door. You ask them if they got underlying heart disease, and they say no. So now we go to the left arm of the algorithm. And our question after that is going to be if it's irregularly irregular or regularly. rhythm? Does it look like it's hitting each solid box right on the money? No, no, I'm sorry, solid line with the 5 boxes in between. Is it hitting the solid lines all the way down? If it is, you got a regular rhythm and you're going to follow the right arm. If it's irregular, uh, more often be dealing with a weird type of atrial fibrillation with Wolff Parkinson White or some sort of aberrancy. But the beauty of it, whether it's atrial fibrillation with aberrancy or whether it's atrial fibrillation with a heart rate of 200, no matter what it is, if they're unstable, back to what you guys answered before. Anything that's unstable, in other words, anything with altered mental status, uh, in the settings with shock, you're going to cardiovert these guys. That's the easy part. Hard part is what happens when they're up, alert, and awake and talking to you, and they got a 90 over 60 pressure, which, yeah, it's low, but he's up, alert, and awake and talking to you. So that makes it more of a stable condition. So we're going to have to give medications. You can make them unstable by coming at them with paddles and shock at the side, in which case they'll pass out, and then you got an unstable rhythm. You probably got a scared to death patient. So going to go with stable if they're alert and awake and just go with the medication route first before we acute and try to do any kind of cardioversion. Cardioversion carries its own procedure. You're going to have to do some conscious situations, folks. But again, come at them with paddles and they'll probably pass out. Now, if they're stable, you're going to go with probably amiodarone or cardizem. I use the ABCs here. The adenocard is not going to be, it's going to make you unstable. Beta blocker could be used, ABC. So the A is actually going to be for amiodarone. You can go ahead with the amiodarone if you're not clear. You can make this very simple. Let's see, neurocomplex tachycardia, adenocard, Y-cup tachycardia, amiodarone. If they're unstable on either one of them, they get cardioversion. That's a good way to start. Now, if you carry cardizem, diltiazem, or if you cover a beta blocker, Lopress or labetalol or whatever it is that you're going to use to slow the rate, or if you just got adenocard or amiodarone, this should not be hard for you. So again, I'm going to walk you through this very slowly. You may start out with adenocard. Wide complex tachycardias, you can start out with amiodarone. Both the narrow complex and the wide complex tachycardias, if the patient has all vital signs that are shocky, both of them are going to get cardioversion. So we've taken all these algorithms and we've boiled it down to a very usable format that you can use in the field. And this is not a one size fits all, but the initial treatment pattern that you get into, whether it's adenocard or amiodarone for the stable neurocomplex or wide complex tachycardia, at least you can get the first medication on board. It's a very stressful situation. Patients probably sitting in front of you, hanging on by their fingernails onto life. And your first couple of actions are going to be very important. So either break out the adenocard or get the amiodarone going, but get something going if they're stable. If they're unstable, you know what to do. You got to set up for a cardioversion. Any questions on that boiled down format? Yes or no? Okay, a couple of good statements in there. Number one, what about lidocaine? Absolutely, Martin. Absolutely. If you don't want to use amiodarone, you like that real quick, I can give this lidocaine and it has a half-life of 33 minutes. So once I give a bolus, I can take my time getting likely not. I can start an IV in the room, push the lidocaine, put them on a stretcher, get them into the rig, then start milligram per minute lidocaine drip. That would be perfect. You got 33 minutes before the lidocaine wears off. At 1 to 1.5, just like you said. The other thing that you mentioned in here is would I still use with a prolonged QT? If I've got one of those heart rhythms where I can actually see intervals, then I would not give medications. However, when we talk about tachycardias, we're talking about rates over 150, and on an EKG strip, if you have a tachycardia that's really wailing, really 180, 190. I don't know that you'll be able to tell a QT interval, and I doubt even the computer can pick up a QT interval, to be honest with you. So I don't know how to, in terms of what do I would do in a tachycardia, as true blue tachycardia that's resulting in an unstable condition or a person who may become unstable. I certainly would not give medications, especially the calcium channel blockers, when there's a prolonged QT interval in any other type of risk. Okay, so let's go back up to the top now. Why complex tachycardia? Underlying heart disease, yes. Ventricular tach. What do I go for? If he's stable, lidocaine or amiodarone. If he's unstable, I'm going to shock him. Cardioversion, and make sure you're very clean on that. You're going to list defibrillation as one of your choices. If you circle it, you're wrong. For the sake of the question, you're wrong. The field, due to cardioversion anyway. It should be right on the R. The strip will have it. It's good proof that you did a cardioversion, not a defibrillation. Back up to heart disease. What if you got a Y complex tachycardia and the patient does not have underlying heart disease? Well, then it could be one of the following. Make a determination. Is it regular? Is it irregular? Let's say it is regular, and we go down the path. We got a regular V-tach or some sort of wide complex tachycardia. You can use adenosine in that particular situation as long as you're comfortable and confident that wide complex tachycardia is hitting regularly. I don't know what to say about that. For the test purposes, if it's hitting regularly and it's a wide complex tachycardia, go ahead with your adenosine. If it doesn't terminate, you're right back to amiodarone and lidocaine anyway. If it does terminate, then you probably had some sort of real fast SVT that looked like VTAC. And that's the beauty of the regular rhythm of the whole thing. VTAC itself is going to be regular as well, but the patient's got to be pretty unstable at that point. And you're just watching some of your questions here. And plug it in the charger. I was about to lose you. Okay. We did the right arm of it. We'll go back to it again. Let's go back over to the left. What happens when you arrive on the scene and you got your 75-year-old male sitting there and you ask him, geez, you look like you're having an attack here, some sort of supraventricular tachycardia, but the QRSs are greater than 0.20 seconds. Do you have any history of underlying heart disease, coronary artery disease, stent placement, cardiac bypass surgery? That's it. 3 questions. That's it. They say yes, it's VTAC, amiodarone or lidocaine. If he says, no, I never had a problem in my life and such, do you take theophylline or digoxin? No, I don't. Very good. We're going to determine it at the end of the strip, or like one of the folks here mentioned just a little bit ago, do a 12 lead, obviously to make sure that you know exactly what you're up against. And you determine this patient has a regular rhythm. It's dropping every black line, every dark line, every 5 boxes, perhaps every other box, which would be a rate of 150, or every box, which would be a rate of 300, or interpolate between the two. If it drops halfway in there, you're probably sitting there around a rate of 225 somewhere. And the bottom line being is, what's the vital signs looking like? What's the mental status looking like? Is it altered? If it's altered, you go to the unstable arrhythmia, which is cardioversion. Okay. Now, if it's regular rhythm and it looks like it's hitting every one of those black lines, and you feel very comfortable that the patient's status is proper and his vital signs don't look too bad, you're not looking for perfect, but not too bad. The big point being here, clear sensorium, be able to answer your questions, then you go ahead and try your adenosine. Personally, I think I'm going to be ending up with these patients on a lidocaine drip or an amiodarone drip anyway. I tend to move towards the amiodarone. You would not be wrong doing amiodarone. Okay. For the purposes of this algorithm, for the purposes of the study, a wide complex tachycardia in a patient who does not have underlying heart disease, who's shown a wide complex tachycardia, which is regular, in other words, hitting in irregular intervals, you go with the adenosine. Now, if the adenosine terminates it, great. You probably had some sort of SVT going on or some sort of WPW going on. Adenosine safe there. This is where cardiosim can kill people. In Wolf Parkinson White, this is why I shy away from calcium channel blockers in a wide complex tachycardia. If it doesn't, you're probably dealing with a VTAC and you're back to lidocaine or amiodarone anyway. All right, not to belabor the point, fictitious for a reason. This arm of the algorithm here is tested more often on the National Registry than the left arm. I'm dividing the arms straight down the middle here. Now, back up to the top again. What if the patient tells you he does not have underlying heart disease? He says no, and you look at the EKG and you show, this isn't falling every 5 boxes. It's 3 boxes here, 2 boxes there, 5 boxes here, maybe 7 boxes here, back to 2 boxes. Looks very irregular. One glance at a nice 12-lead EKG, and you can tell if it's regular, irregular in most cases. So, if you got cardiology calipers, you may want to march them out. You put it on the one QRS and you just, march it along like you're marching points on a map and see, does it go to the next QRS? Does it go to the next QRS, et cetera, et cetera? Is it sitting right on point? So let's say in this particular case now, instead of being regular, it is now irregular. And so we wide complex tachycardia, which is irregular. Well, back to your common sense stuff. Let's deal with stable one first. Definition unstable, vital signs which aren't quite right. They can be obviously they're very tachycardic. But the thing that's going to call it stable versus unstable is going to be altered mental status. Roll unstable and stable all day with symptoms. Unstable, well, the patient's alert and awake. He's short of breath, difficulty breathing, pulse oximetry 70%, and he's running into some real problems. He's got a wide complex tachycardia in his EKG. You call it unstable. The patient's got an over 60, 100 over 70 blood pressure, heart rate's 180, but his mental status is altered. That's unstable. It's usually all this that makes a decision for you. So you go to unstable here after you detected that the patient has no underlying disease, has an irregular heart rate, and you go unstable, and you can see there that the patient is probably in some sort of polymorphic VTAC. In other words, firing from all kinds of foci. And so it's going to be, in other words, not one focus is firing at a regular rate or from one part of the heart, which will give the appearance of a regular rhythm, but it's coming from all sides. Now, fib, I'm not sure why they put it on there. I don't consider VFib a wide complex anything. I consider it its own little category of algorithm. I don't know anybody in VFib who's conscious, alert, and awake. So by definition, obviously unstable. In that particular case, you apply defibrillation, not cardioversion. Defibrillation. If you're checking for pulses. If you got pulses, then you're going to go ahead with your lidocaine or amiodarone. If you don't have pulses, or if you've got an altered mental status patient in VTAC, you treat it with defibrillation anyway, and you will do a defibrillation if the patient's unresponsive. And you put your fingers on the carotid, and you see VTAC on the monitor, and you don't feel pulses. A pulseless VTAC is treated just like ventricular fibrillation. You apply defibrillator pads. Now, if the patient does have a pulse, okay, anytime he's got a pulse in the present regular or irregular ventricular tachycardia, but with unstable vital signs and an unstable finding of altered status, you're going to do cardioversion. All right. So back up to your unstable. He could be in atrial fibrillation with WPW. He could be in VTAC. What do you care? You're going to do your amiodarone. You're going to go with your cardioversion first. If they have no pulses, you're going to do defibrillate, and then you'll get your amiodarone started. If they're stable, atrial fibrillation, it could have WPW with it, lidocaine or amiodarone going to be the mainstay therapies here. Now, the National Registry has typically their tests are up 3 to 5 years behind the times. However, amiodarone now has been around long enough where they're entrenched now even in textbooks, and textbooks are only printed every 4 to 5 years. It's certainly in the standard of care. Paramedic systems, if not all of them, carry amiodarone because it is safe and efficacious. Not too many situations that you get into where amiodarone is going to hurt the patient. At worst, the worst thing that can happen with amiodarone is it's not going to do anything. The best it could do is cure the problem, either by slowing it down or even converting it. But it's not going to really harm your patient. There are some contraindications to it, but from our standpoint in the field, as we arrive on the scene of a whatever, you're going to find that amiodarone start for the wide complex tachycardias. For the narrow complexes, I like to start with the medicine. All right, back down to ventricular tachycardia. The patient has no underlying disease. You determine the rate is irregular, and yet he's stable. So you go down there to the last one there, and it looks like atrial fibrillation aberrancy or atrial fibrillation with WPW. Look, if the patient's stable and he's talking to you, you want to get the rate down. Starting an amiodarone drip is going to be perfectly fine. Cardizem in the setting of WPW, in other words, Wolff-Parkinson-White disease, is going to make the rhythm unstable. It'll throw you back over to the left arm. You're going to be doing a cardioversion or worse yet, a defibrillation. You could very well throw them in the V-fib or VTAC. So National Registry exam is going to give you a negative. In other words, you're going to slip a question through the back door that says, can you use it? What medication here is not indicated for this rhythm up here? And so you're going to have to identify that it's a wide complex tachycardia, and if it's really irregular, but the patient's mental status is normal, vital signs look okay, which medication not indicated, one of those choices is going to be cardizem or diltiazem. They try to avoid trade names on the National Registry exam. By printing a trade name, they're making a product endorsement. So you're going to have to know the generics, the generic names for each one of these medications so that you don't get confused on the exam. So in this particular case, Tiazam, Verapamil are going to be contraindicated because they're calcium channel blockers. Now, this pertains only to the arm that goes from underlying heart disease to no, to irregular rhythm, stable condition, down to atrial fibrillation with aberrancy or with benign WPW, Wolff-Parkinson-White. It's the only time that your calcium channel blocker is absolutely contraindicated. However, since some of this stuff looks like mush on the scene where people are excited, you've got yourself and your partner. Fire department may or may not have augmented with more personnel on the scene. So you're going to have two hands to work this patient. So I wouldn't get myself necessarily in right away. I just remember, wide complex, I'm going to do the amiodarone. Oh, he's unstable. I'll do the cardioversion. Well, he's pulseless and unstable. I'm going to do defibrillation. Boil it down. Boil it down to the same thing that we do as ER physicians. Boil it down to as soon as I hit the room and somebody slaps me in the face and says, hey, I got this, and this. The first thing out of your mouth will be what you want to do first. Then you'll have time to think about it because nobody can pull up out of the cart, drop their medications, get the IV started, and push the medication right away in less than 10 seconds. You're going to have at least a full minute to think it through. You're going to look at the EKG strip. After you've ordered the identicard in the case of a narrow complex tachycardia, you're going to ask for the amiodarone to be set up at 150 IV push, over 10 minutes, or IV pigment over 10 minutes until we can get this thing straight. Or you're going to ask for a defibrillation cardioversion right away. Like, people are going to have set up for that. You've already made the call. I'll give you a few seconds to think it through. At least have those first one or two actions in your head, what you would do no matter what kind of tachycardia you're faced with. Okay. All right. I know I've been talking pretty fast here, so let me break for one question. And anybody have any questions, yes or no? All right. I'm waiting to see if Martin, how do you distinguish between course VFib and Torsade when it comes to magnesium sulfate administration? That's a great question. Torsade is going to be pretty much an irregular rhythm. However, you're going to see large swings in the QRSs, and then it's going to look like it goes around a corkscrew. It's going to change direction and go the other way. Now, you may say, well, it looks like it's high, small, high, small, high, small, large, small, large, small, large, small. Corkscrew, I don't really see a corkscrew, but I can see that it kind of looks different here with the peak being down, and then over here it looks like the fuse is kind of up again. And Torsade is one of those weird arrhythmias where you can safely say that it'll be pulsed. More often than not, it's going to be pulsed. Anything that is going to get defibrillated anyway. VFib isn't going to be pulsed at all. And it's going to be not only erratic, you're not going to get wild swings on the ventricular fibrillation like you do with the Torsade. Torsade's going to really take your strip. If you're running a 12-lead strip, you're going to see it really move from the baseline, whereas VFib is going to be a little bit smaller. Treatment for Torsade, magnesium, you nailed it. You're right on 1 to 2 milligrams IV piggyback, and you can get the Torsade pretty well under control pretty quickly. But distinguishing between the two, if I see something funny, I'm going to ask the patient how you feel. If they're answering me, it's not VFib. Fingers on their carotid, talk to them. If the Torsade's patient is unresponsive, treat it as an unstable rhythm, and I would probably cardiovert the patient anyway. But if they do have pulses and the vital signs are pretty good, magnesium is going to be indicated. So it may have sounded redundant over the past explaining the differences, but I went back and reiterated once again. Go back to your original instincts. If they're pulsed, it's got to come down to whether or not they have a pulse of altered mental status. Anything that's involving altered mental status and no pulses gets defibrillated. Altered mental status with pulses gets cardioverted. Mental status, which is normal, and they do have pulses, then your Torsade's going to get magnesium. That's exactly right, Matthew. That's what you got it boiled down to. The objective is, this isn't to teach you cardiology, although if you guys do have with me, if you come to this area and want to spend the day in the emergency department with me, we'd love to. If you're not in the Texas area, you don't have those opportunities, boxes and pound defibrillators and such, you thought you were carrying in an electrical transformer. And those watt machines went up to 500, 600 watts when the feeling at that time was felt the more electricity, the better off you were. All did an autopsy is just determine whether the heart was medium to 250, 300, 200, 240 to 300 watt seconds. And I don't even see the algorithms going over 300 anymore, to be honest with you. But back then, the principles were the same, narrow complex versus wide complex. At that time, we carried a lot more medications than we do now, but we didn't have amiodarone and tensilon and procanamide, which has been around for eons, is still a great drug. But the principles are the same. And the principle is, are you narrow complex? Then my decision is either a regular or irregular rhythm, and I act from there. Is my tachycardia wide complex? Then my first determination is, do you have heart disease? Yep, you're in VTAC. No, you're not in VTAC. Let's look for something else. Are you regular or irregular? It comes down to just real in here, real basic questions to keep in your mind. But this is what separates you guys from EMTs and from nurses and some of the other folks out there who are not intensively in EKG interpretation. You could be the best EKG interpreter out there, but without a game plan backing it up, and without the appropriate questions following it up, that's all you are, is a great EKG interpreter. As soon as you look at that EKG, narrow or wide, and then initiate the appropriate algorithm from there. It goes pretty easily from there. So, to review, I walk in the house, and here's going to be your scenario, so listen up. You arrive on the scene of a 75-year-old male who's complaining of chest pain, shortness of breath, and some difficulty breathing. He was sitting watching TV when all of a sudden he started difficulty breathing. You arrive on the scene, you see the patient has some cyanosis around his lips. You put on initial oximetry, it's 88%. He's complaining mid-sternal chest pain radiating up into the left neck and jaw. What's your first actions? What you're going to regurgitate to me is the scene safe? PPE on, my protective gear and such. And then you're going to get into the questions. You're going to put a pulse ox on. You're going to ask him, when did this start? Started just a few minutes ago before we called you. Any recent surgeries? Yeah, I open heart bypass surgery 5 years ago. Yes, I take the following medications. Lisinopril. I had a blood clot about 5 years ago in my legs as well. My heart doesn't have a regular rhythm. So you get the oxygen 15 liters non-rebreather on him. You start an IV. You get him sitting in a position of comfort. You put the 12 lead on him because you're going to ask me for a 12 lead, right? Right. And then I'm going to tell you, what do you see? And then on your screen, or I'll describe it to you either way, I'm going to describe to you an acute myocardial infarction. I'm going to give you the leads, 2, 3 AVF with reciprocal changes in 1 ADL V5 V6. I'm going to ask you how you're going to handle this case. And then I'm going to throw the arrhythmia up there. Now you're going to go with your nitroglycerin, you're going to go with your aspirin, your morphine, the morphine, oxygen, nitro, and aspirin. You can't forget that. But this is where the arrhythms change now. I'm going to give you the MI, but I may put it in the setting of a narrow complex tachycardia or a wide complex tachycardia. At that point, you're going to give back to the algorithm. I'm going to ask you how you determined it. And then you're going to run the algorithm for me. Just next couple of questions. Underlying heart rhythm, and I throw up there a EKG that shows an inferior wall MI with lateral wall extension or an inferior wall MI. Don't forget to ask me for the RV4, B8, B9 leads to see if extended, which I can assure you it will. You're not going to get off easy on my medical director exam. So you're going to be looking for your posterior wall MI. You're going to give the fluid boluses because I'm going to give you an 80/60 pressure. But what I'm going to give you is a patient who has perfect normal status is going to say to me, okay, this is regular rhythm. This could be unstable condition. Is it going to be stable condition? It's going to be a stable condition. The patient is then going to deteriorate into a rhythm. And it's going to be that rhythm that you're going to have to interpret for me. I'm going to throw you up something now. It's either going to be atrial fib rapid response, VTAC, VFib. It's going to be one of the supraventricular tachycardias, such as multifocal atrial tachycardia in the case of a COPD or zontheophylline. I'm giving you all kinds of scenarios here, and which way I branch depends on cases that I've seen that week or something that I want to just mix up so that not always get the same scenario all the time. There are going to be some basics here. And the basics are going to be, are you asking the appropriate questions? Are you discerning the appropriate arrhythmias? Are you then taking it through your algorithm in your mind? And then how do you react to a changing condition? Remember, good medicine, bad outcome. I followed the algorithm. I gave all the proper meds, but it deteriorated. Well, you know what? Stuff happens. There's bumper stickers out there that say that. Good medicine, bad outcome. No matter what you do, patients still deteriorate. So during that deterioration, you need to think pretty quick on your feet. I may throw a second strip up there that shows the torsade that was brought up a little bit earlier, or the patient deteriorates completely into VFib, in which case you'll have to run your ACL. But in there, you're going to get a strip, either wide complex or neural complex, regular or irregular, in the setting of heart disease or no heart disease. And you're going to have to run for me. But since we've already had this boil down session, because you're good enough to attend this, so I'm good enough to throw something at you. You're going to start me off with either amiodarone or adenosine or a cardioversion. So, anybody have any questions right now? All right. All right. Well, I covered everything in probably record time here. I'm not sure why. Um, Practice sessions that I had with this lecture, it's gone at least 50 minutes or so, and I don't, 20, 55, maybe I'm there. Okay. All right, let's wrap this up then. Does anybody have any questions for me as far as any questions at all between narrow complex and wide complex tachycardias? All right, well, while we got a few seconds, I wanted to show you something here. There's been some studies coming out recently that have been a little bit disturbing. It's actually shaking the rafters and the foundations of everything that we've ever learned since the beginning of time when it comes to resuscitating from use and survival on patients at outpatient cardiac arrest. There is a growing number of papers that are hitting the big publications. What I mean by big populations is any big medicine articles, New England Journal being the big one, obviously. But we've got several other really good publications out there. Let's see where this one's from. So, has this big study out there, and they're asking, are we really making a difference with epinephrine? Consensus right now is that we're still using epinephrine in our algorithms and such. However, I want you guys to read that article. You're finding that it's not making much of a difference for the patient walking out 30 days later. In other words, yeah, I can resuscitate them in the field, but nobody's really doing well after 30 days. So does the epinephrine do something like blood flow? Well, there's already a restricted amount of blood flow to the brain. Is epinephrine making that worse? Should we be just doing CPR and nothing else in the field? Now, if that doesn't shatter your foundations of everything you know about medicine, I don't know what does. When I read the article, of course, I don't jump on every article, go into the emergency room the next day and say, hey, I just read a paper last night on this, so you're not getting any epinephrine. We're just going to beat you until finally somebody decides that they're too tired, can't go on anymore. That's not the way we operate, but it is something that we have to watch for. Just know that there's studies out there that are questioning the use of epinephrine in cardiac arrest now as to the final outcome. You did your job. You gave him epi. You did good, high quality CPR, I think we call it. And you got the patient intubated. You got them into us. We got pulses back. I put them on the 3 pressor drips that they need. Sent them up their heart. You, and you think that everything is fine. Well, everything is not fine. These patients aren't going out the door neurologically intact like we'd want them to after 30 days. And so they've been working backwards on the research here to try to figure out, is it something we did in the cath lab? Is it something we did in the ICU? Is it something that you did in the ER, doctor? Or let's start taking a look at the basics. Epinephrine really making a difference here? Or is it making things worse? So just know that it's out there, and who knows what it's going to look like 5 years from now. But if you get a chance to read the article, just to know that not everything is as it seems. All right. Well, if there's no questions, then what I'd like to cover next week, let me look at my calendar.